Hello all in Prague. My name is Ibiyo Lawrence, and together with Olayiwola Bolaji, my fellow, we will be presenting a paper which was published recently termed The Long-Term Cognitive Outcomes Following Post-TAVR Stroke, a propensity-matched analysis from the TriNetX Network. We have no financial disclosures at this time. We will be discussing the cognitive trajectory after TAVR, which is the transcatheter aortic valve replacement. I'd like to spend a few minutes talking about what aortic stenosis and the TAVR procedure actually are. So aortic stenosis is defined as the progressive narrowing of the aortic valve, which then leads to a left ventricular outflow obstruction. It's actually the most common valvular disease in the older adults, and it's most commonly caused by age-related calcific degeneration, and sometimes it can be termed as aortic sclerosis due to the calcific degeneration. It's classified into A, B, C, or D. By the time you get to class C, you have severe aortic stenosis, which can either be symptomatic, that's a class D, or asymptomatic, which is a class C. And by the time most patients require TAVR, a lot of them have symptomatic aortic stenosis. As the U.S. population increases, severe aortic stenosis is becoming an increasingly important cause of morbidity, mortality, and healthcare utilization. Severe aortic stenosis is one of the most important cardiovascular diseases affecting older adults. As I mentioned earlier, it results from progressive calcification and narrowing of the aortic valve, and this leads to obstruction of blood flow from the heart. The prevalence increases dramatically with age. Approximately 5% of Americans over the age of 65 have aortic stenosis, and among adults over the age of 75, about 12% have some degree of disease, while 3 to 4% have severe aortic stenosis. As life expectancy increases, the number of affected patients continue to rise. For geriatricians, the importance extends beyond survival. Severe aortic stenosis contributes to frailty, falls, functional decline, heart failure, hospitalization, and reduced quality of life. The advent of TAVR has revolutionized the treatment for these older adults, making it possible to offer valve replacement to many patients who previously would not have been surgical candidates. The growing burden of disease underscores the importance of understanding not only the survival outcomes after TAVR, but also the long-term cognitive and functional outcomes, which are the focus of our study. So the question is, again, why does it matter? Untreated symptomatic severe disease is associated with substantial mortality, and increasing life expectancy is driving a growing number of patients eligible for TAVR. Preservation of cognition, function, and quality of life are the major goals in older adults undergoing the valve replacement. What is TAVR? TAVR stands for transcatheter aortic valve replacement. It's a minimally invasive procedure used to treat severe symptomatic aortic stenosis. It's actually an alternative to the surgical approach, which is called the surgical aortic valve replacement (SAVR). Before discussing our study, it's important to briefly review the TAVR procedure. TAVR, or as we call it, transcatheter aortic valve replacement, has transformed the management of severe aortic stenosis, particularly in older adults who may not be ideal candidates for open heart surgery. The procedure involves delivering a bioprosthetic valve through a catheter, most commonly the femoral artery, and deploying it within the diseased aortic valve. Over the past decade, TAVR has expanded from use in high-risk patients to becoming a standard of treatment across nearly all surgical risk groups. While TAVR has demonstrated excellent outcomes in terms of survival and symptom improvement, neurologic complications still remain a concern. Stroke is amongst the most feared complications because of its potential impact on cognition, independence, and quality of life. For geriatric patients, These outcomes are especially important. Patients and families often value cognitive preservation and functional independence as much as, if not more than, procedural survival. This concern provided the motivation for a study examining the long-term cognitive consequences of post-TAVR stroke. Over 200,000 procedures are performed annually worldwide, with procedural success rates exceeding 95%. Neurologic complications such as stroke occur in approximately 2 to 3% of cases, and silent brain infarcts, though, can occur in up to 76% of patients. Again, TAVR is increasingly used in older adults with severe aortic stenosis. As we all know, stroke is still a recognized complication following TAVR, and older adults are particularly vulnerable to the cognitive decline, vascular dementia, and functional impairment. Long-term neurocognitive outcomes after post-TAVR stroke remain poorly understood. TAVR has actually revolutionized the treatment of aortic stenosis, and it's expanding rapidly to include lower risk populations. However, it's the complexity of the interplay between the vascular injury and the neurodegeneration still remains unknown, and it's a critical concern that as life expectancies post-procedures are being affected. This is an image showing what the TAVR procedure looks like. This shows the bioprosthetic valve being deployed through the femoral artery into the aortic valve to replace the diseased valve. This photo compares this TAVR with the SAVR, which is the open surgical aortic valve replacement, which is an open heart surgery, as opposed to TAVR, which, as I mentioned before, the bioprosthetic valve is introduced through the femoral artery into the heart, and this is definitely a less invasive procedure as opposed to an open surgical procedure. So the question is, does post-TAVR stroke increase long-term risk of cognitive decline? We will now proceed with the study objective. The study aim had a primary and a secondary objective. The primary objective was to evaluate whether post-TAVR stroke is associated with vascular dementia and mild cognitive impairment, while the secondary objective was to identify predictors of long-term cognitive decline following TAVR. What was the hypothesis? The hypothesis was patients experiencing post-TAVR stroke will demonstrate increased long-term cognitive effect. It was a retrospective cohort study, and it was a propensity score matched analysis. The database was a TriNetX Analytics Network, and it was a multi-institutional real-world database. The study period was prolonged. It was a long study period from 2010 to 2025. The population included were adults who were 65 years and over undergoing TAVR, and the total cohort had 57,506 patients, which was a large cohort. The cohort selection included patients who were 65 years and above and underwent the TAVR procedure. The matched groups had post-TAVR stroke cohort of about 2,600 patients and a no-stroke cohort of 2,600 patients as well. The matching method used was the propensity score matching. They also had balanced baseline characteristics as shown here. The key features of the study population included older adults, older TAVR population with a mean age of 79, plus or minus 7 years. They had a high cardiovascular risk burden as well as multiple chronic comorbidities. It was a real-world multi-center cohort. The propensity matching achieved improved comparability between the groups and also reduced confounding bias. The primary outcome was measured at 1, 3, and 5 years, and they included vascular dementia and mild cognitive impairment. The outcome at 1 year showed 3.1% incidence of vascular dementia in the stroke group and 2.4 in the non-stroke group, with an adjusted hazard ratio of 1.29 and a p-value of 0.137. This shows a trend toward higher early vascular dementia risk, but did not reach statistical significance. This shows a difference in outcomes at 3 years and 5 years. The 3-year outcomes showed 4.5% versus a 4.1%, with an adjusted hazard ratio of 1.09 and a p-value of 0.51. At 5 years, outcome was 5.3 versus 4.9%, with a hazard ratio again of 1.09 and a p of 0.456. This key finding is that the difference is attenuated over time. In terms of mild cognitive impairment, the findings showed similar MCI rates between the groups with no significant differences at 1, 3, and 5 years. Clinical interpretation of this is that post-TAVR stroke may not independently drive long-term MCI development. So what were the independent predictors? There were some significant independent predictors of cognitive decline, and they included increase in age, anticoagulation use, chronic kidney diseases, with increase in age being highest risk marker with a p-value that was statistically significant, and it was less than 0.001. This highlights the fact that traditional vascular risk factors may outweigh stroke alone. The reason why anticoagulation is a significant independent predictor can actually be attributed to a highly vulnerable vascular system, as demonstrated in the Envisage TAVI AFib trial mentioned here. Cognitive decline post-TAVR is not just a localized neurologic event, it's actually a culmination of chronic systemic failure. This data proves that we cannot treat the valve in isolation. The brain's survival depends heavily on managing the systemic inflammation and vascular damage driven by the kidneys and chronic hypertension. So what are the implications for geriatric care? The important takeaways for this include a stroke surveillance remains important after TAVR. Longitudinal cognitive monitoring should be integrated into care, and management of vascular risk factors remains essential, as well as a multidisciplinary follow-up may actually improve outcomes. There should be a geriatric focus on frailty as well as cognitive decline and cognitive trajectories. There should also be a focus on shared decision making, whereby patients are informed of all the complications of the surgery and the potential outcomes of the surgery, such that they make an informed decision, and as much as possible include the family members. So what were the strengths of this study? Included a large multi-center cohort with a real-world data. If you remember, I mentioned that there were over 57,000 participants in this study. There was also a longitudinal follow-up, which was prolonged. A lot of these patients were followed for as long as 15 years. The propensity score matching was also in place. As with every study, there has to be limitations. So what were the limitations of this study? The limitations included it was a retrospective observational design, there were potential coding inaccuracies, there was residual confounding, and there was also limited granularity of neurocognitive testing. So, what are the areas of future studies? Well, the areas of future study include, but are not limited to, prospective cognitive assessments after TAVR, biomarkers of neurovascular injury, the role of silent infarcts in these patients, as well as frailty and cognitive resilience. It's also important that we look into preventive neuroprotective strategies. Again, as TAVR continues to grow in popularity, it becomes clear that the structures need to be put in place to actively protect the brain over a lifespan. It's also important to consider routine cognitive screening of the candidates prior to the procedure. It's been shown that almost 40% already have cognitive deficits. This will help with procedural planning and cerebral embolic protection to prevent the one-year spike in vascular dementia risk caused by embolization. In conclusion, long-term cognitive outcomes after TAVR are multifactorial and require comprehensive geriatric cardiovascular care. And I'd like to thank you, and here's a link to the study and our email addresses. Thank you very much.